A very good morning to all of you. Welcome to another episode of Weekly Sunday webinar series organized by SHRI Knowledge Academy. Today we have a very interesting topic regarding dermatology. Before moving on to the lecture, let's go to see some housekeeping rules. The webinar will be open for you to join in from 9:15 to 9:45 a.m. No late attendees will be permitted to join thereafter. You should stay until the end of the lecture to collect the CPD points and the e-certificate, and the link for the e-certificate will be posted in the chat box at the end of the lecture. If you have any questions, you can type it in the chat box, or you can ask at the end of the lecture directly from the lecturer herself. Moving on to today's topic. Today's topic is fungal skin infections and their management. And our guest lecturer is Dr. Rantilaka R. Pranavaka, who's a consultant dermatologist in Lady Ritchie Hospital for Children. She has 28 research publications in index journals, and she is the author of 27 book chapters internationally. Also, she is the editor and author of eight medical books nationally. So she has a vast knowledge regarding this topic in her field. Dear Madam, over to you to conduct your timely lecture, and thank you for joining with us today.
Hello, good morning.
A very good morning, Madam. Thank you for joining with us today.
So today's topic is fungal skin infection, diagnosis and management. So I'll be talking about one thing is superficial skin infections. That is about skin, hair and nail infections. Then separately, I'll be talking about onychomycosis. Then subcutaneous skin infection. Those are in deep layers of skin. And systemic and deep infections, I will not go on detail. So superficial skin infections, there are yeasts. Candida also a yeast. Other than that, malassezia, which causes pityriasis versicolor, that's aluhang, dandruff, and seborrheic dermatitis. And there are dermatophytes. Tinea infections, all types of tinea infections, and Kiria. So there are non-dermatophytes or mold actually causes problems in systemic infections like aspergillosis, fusarium infections. Those are non-dermatophyte molds, and also onychomycosis and also candida. So I'll be talking about onychomycosis in detail as well. So in tissues, there are two forms, fungi in two forms. One is filamentous or hyphae. The other one is yeasts. So filamentous or hyphae, dermatophytes and molds. So when you look at under KOH or potassium hydroxide in microscopy, you can't differentiate what is the fungi, but you can say that it is either a dermatophyte or mold. Or yeast. Yeast can be candida or malassezia. So this is pityriasis versicolor, or we call it Tinea versicolor. And the causative organism is Malassezia species, and it is a lipophilic yeast. And usually this versicolor is caused by Malassezia globosa or Malassezia zymbodalis, fur. We are not interested actually. What we are interested is, this is caused by a Malassezia species, which is a yeast. So that's important in treatment. So the other thing is, like you can see these hypopigmented patches with lot of satellite lesions, and infants and children, usually this versicolor appear on face. You can see these infants, these hypopigmented patches around the eye. You can see around the eye are versicolor, right? So I request our OPD doctors to treat this, if not cured only, to send us. Because in our clinics, I have to see around 30 to 60 new visits per day, right? So out of them, about 15 are versicolor or aluha. Definitely, OPD doctors can treat this, right? That is why actually I requested these lectures to conduct because we have a real trouble in conducting the clinic because it's overloaded with unnecessary referrals, right? So you can treat versicolor. Don't worry, treat versicolor for 2 to 3 weeks and send to us if not cured, right? So, and versicolor can be hypopigmented or hyperpigmented. So this you may have seen, it's the commonest variety, hypopigmented one. But there's an entity called Kalu Aluham. Even laymen, they know that there is Kalu Aluham, Kalu. So that is hyperpigmented versicolor. So it is asymptomatic, mostly asymptomatic, and it's benign. And it affects only the stratum cornea. It is usually flat, but you may see sometimes slightly raised because it's a fungi. So you can see the fungal hyphae coming over the epidermis, stratum corneum, and so you might see slightly raised macules. They are oval, hypo or hyperpigmented, and you can see mild scaliness. So mostly on the chest, anterior and back, but it can go down to lower limbs. So it's hyperpigmentation. The other most important thing is even if we kill the fungi, this pigmentation may last for many years, right? So we don't treat until this pigmentation disappears. So if the scaling has disappeared, and sometimes they complain after a wash, this become more prominent. The scaliness become more prominent. So if that feature gone, so that means the fungi is dead, right? So we don't treat until this pigmentation, hypo or hyperpigmentation disappear, right? So it takes years to cure. So it's a worldwide distribution, but common in warm climate. So this is the treatment. So on face, in adults and both in children on face, and in children, if it's a mild infection, we give only topical creams. So we can give topical azoles, that is clotrimazole or miconazole, or topical terbinafine cream. So they have to apply 2 to 3 weeks. 1 week is not enough, 5 days is not enough, right? So they have to apply 2 to 3 weeks, right? Then if it is wide body area, these tubes is not enough. You can apply creams, you can give creams, but only thing is that nowadays the antifungal creams are very expensive. 15 tube is around 600 rupees, 600 or more. So it's very expensive to apply on wide body area. So what we do is, we take either ketoconazole shampoo or selenium sulfide shampoo and ask them to apply twice weekly for 2 to 3 weeks or 1 month, right? So in children, because it's a wide area. So in children, we ask them to keep for 1 to 2 hours and wash off. But for adults, they can see if there's no allergy, they can keep overnight. So in textbooks, you might see that they have instructed to keep overnight, but be careful, first check for allergy, ask them to apply and wash it in 2 hours. If there's no allergy, they can keep overnight. But for children, keep for 1 to 2 hours and wash off. So they have to do it for about 1 month, not 5 days, not 1 week, right? It's for 1 month. And for extensive or recurrent cases in adults, we give itraconazole. Itraconazole 200 milligram daily for 5 to 7 days, once only. Because when you give itraconazole, the fungi are dead, definitely dead. There's no resistant in versicolor. So when you give itraconazole, it is dead, right? So give once only. So hypo and hyperpigmentation may last years even after fungi is eliminated. No treatment for that, right? So we don't treat the pigmentation. So when you give itraconazole, the fungi is dead. That is the end of the treatment. No more treatment, right? So I have put eliminated because this versicolor or Malassezia species are commensal in our body. So we can't completely kill them and say, now you are cured, you won't get this infection anymore. No, it is a commensal. So the problem is overgrowth of commensal, right? So there's no elimination. So other forms of Malassezia infection are, one is, you may have heard this, Pityrosporum folliculitis, or we call it Malassezia folliculitis. That's a yeast forms occupying the hair follicles. Back of the trunk, there are some folliculitis. So I didn't give the treatment because it's little complicated. You can send that patient to us. And dandruff is again Malassezia species, and seborrheic dermatitis, again Malassezia overgrowth. So all these are, Malassezia is a commensal, but it's the overgrowth of Malassezia cause these problems. So the next one is tinea infection, or we call it ringworm infection. So when this tinea affect different part of the body, different names are given. So this is tinea corporis, when it affects the trunk, right? So organisms are same in all tinea infection. It's either Trichophyton rubrum or Microsporum species are there, right? Trichophyton also, different species are there. Commonest is rubrum and Microsporum canis. So this is a very itchy condition. You can see this is sharply marginated, right? And with a raised active edge and the central resolution, because the fungi spontaneously die at the center and spread outwards. So there's an active inflammatory edge with central resolution, very itchy condition. So when tinea affects the feet, it is called tinea pedis. Again, if you look at only front part of the feet, you won't diagnose this because the differential diagnosis is eczema. How you differentiate is, look at the lesion carefully, you will see this active inflammatory edge. So tinea cruris is again tinea infection on flexures. So again, look at the active inflammatory edge, right? So you can see this is well demarcated and there's an active inflammatory edge. And the worst thing is this post-inflammatory, they get post-inflammatory hyperpigmentation. This may last for many years, even 20 to 30 years. So like when these young girls and young men get tinea on flexures or submammary area, they have this dark black color last for many years. So that's a big problem. We can't do anything for that. So when tinea is on the face, it's called tinea facies. Now if you look at this person from front, you will see this inflammatory lesion only. But when you look at carefully, you can see this active inflammatory edge. It has spread all over the face because he was prescribed steroid on that. because differential diagnosis is contact dermatitis, right? So look for this edge, because nowadays we have this resistant tinea infection, very widespread. So all these eczematous lesions, before start treatment with steroids, look for the inflammatory active edge, that is tinea infection. So this is on beard area, they get folliculitis. Differential diagnosis is psychosis barbae, that is staph infection. But this was tinea barbae, that's a fungal infection, again like appear as folliculitis. On the beard area, we call it tinea barbae. So anyway, any patient, because tinea barbae is not very common, we first treat with as staph infection with antibiotics. So if not cured, you can start on either griseofulvin or terbinafine, right? So tinea pedis, when tinea infection on feet, you call it tinea pedis, right? So on hands, again, tinea infection on hands or palms, we call it tinea manum. So they come with very itchy condition, lesion. Again, differential diagnosis is eczema, but this is unilateral. Again, in these two patients, you can see it is well demarcated lesion. And there's even on the palm, you can see active inflammatory edge. Right? So active inflammatory edge. So this is tinea manum, we call it. But whatever the site involved, we give different names, but the treatment is same. So in this HNE, if we don't do usually, but if we do HNE, there's nothing you can see. But with special stains, you can see fungal hyphae. These black ones are fungal hyphae. And pus staining, the same patient, pus staining, you can see this fungal hyphae, right? So this tinea infection affects stratum corneum. So management. So whatever the site involved, the treatment is same for tinea infection, right? So if the lesion is localized or recent onset, right, new lesion, we can treat with topical antifungals, topical terbinafine or topical clotrimazole miconazole. They have to apply 2 to 4 weeks topical. But nowadays, topical treatment is not enough. So most of them have widespread disease. So we have to give oral terbinafine, 250 milligram daily for 3 to 4 weeks. Actually, all the white or Western textbook says 2 weeks, because that is not drug-resistant tinea. What we have is now drug-resistant tinea infection. So 2 weeks is not enough. So we have to give either 3 or 4 weeks. Sometimes we go further. Itraconazole, they have to give 100 milligram daily for, again, same period. But the problem is gastritis. So usually I don't treat with itraconazole for 4 weeks, because definitely everybody gets very severe gastritis, right? So if you go for 4 weeks, better to start with terbinafine or griseofulvin. Griseofulvin, 500 milligram daily for 4 weeks. So all these drugs, the problem is liver damage. So if you go further after 4 weeks, you have to check for SGPT. Check SGPT and then continue, right? So what is don't? Very important. Do not ever use topical steroids or steroid plus antifungal combination on suspected fungal infection. So if you have a doubt whether this is eczema or fungi, if you are sure that it is eczema, you can start on steroids. But if you have a doubt, you are not sure whether it's fungal or tinea, don't give steroids. So what happens is, with steroids, the inflammation subsides. So initially, patients feel that they are cured for few days. About 5 days it will last. Then they get a flare up with more like a widespread infection. So never use Candid B, Candacort, Pevizone, Beclomine, Travacort, Enderm-GM, very commonly used. So don't ever use these combinations. Candid B has antifungal plus B is betamethasone. Here, Candacort, antifungal, Cort is steroid. Here, Zone is steroid. Travacort, steroid, right? So here, in the MGM, they have mentioned clobetasol, gentamicin, miconazole. So clobetasol is their steroid. So don't ever use steroid on suspected fungal infection. So this is what happens. This is very widespread tinea infection. We call it tinea incognito. And this is drug-resistant tinea, what we see today, caused due to this steroid use on fungi. So you can see, like in tinea, when we use steroids on fungal infection, we can't see this active inflammatory edge, but still you can see it is well demarcated, right? So fungal growth has stopped here. So you can see it's well demarcated, right? But you won't see active inflammatory edge if they have applied steroid or partially treated. So do not ever apply this combination on suspected steroids, suspected fungal infection. So the other one is tinea capitis. So that's tinea capitis is this tinea infection on hair shaft. I took it separately because one is the causative organisms and their invasion are different from the other tinea infection, and the management also different, right? So tinea capitis, there are several types, but it's not important for our management. So these species, same species, Microsporum, Trichophyton, Ectomophyton, same species causes tinea infection of hair also. Clinically, you can see either patchy hair loss. This child has patchy hair loss, right? Or it could be diffuse hair loss. So usually parents complain that there's hair loss on this area. That is their complaint. But when you look at carefully, you can see those are well demarcated lesion. Even in the upper one, you can see it is well demarcated. If you remove hair and see, you can see the active inflammatory edge, and it is well demarcated. And the normal skin is very clear here. Here also, unaffected skin is very clear, clearly demarcated from the infected skin. So there are broken hair, there are inflammation and scaling, but both may be minimal. You may not see those things. So, but there are inflammation and scaling. So that is tinea capitis, commonly on children, right? So what are the differential diagnoses of tinea capitis? So differential diagnosis is, this first one is tinea capitis. Second one, alopecia areata. Third one, we call it trichotillomania or hair pulling disorder. We don't call it trichotillomania. When you call it mania, it's a psychiatric illness. But this is not initially it's not considered a psychiatric illness or psychological illness, right? So all these three are patchy hair loss, start as patchy hair loss. Itching may be a feature in all. So first one, this tinea capitis is itchy. But alopecia areata is not itchy, but they complain of some irritation. Irritation before this hair falls, right? So they may interpret that as itchiness. Again, this hair pulling disorder is not itchy, but they might tell that is itchy. That's why I take off hair, right? So itchiness may be a complaint in all three. So in tinea capitis, there are scaling, inflammation, itchiness, and broken hair. So in alopecia areata, this is skin is very smooth, no hair at all, no broken hair, right? No hair at all. There's no inflammation and no scaling. Skin is very smooth, right? So that is alopecia areata. So hair pulling disorder. So it occurs on easily accessible site, right? Only on easily accessible site. So when they come to us, large area affected, right? Large area is affected. So there are broken hair, and because they pull hair, there can be bleeding spots. And parents, also the patient, admit. The parent have noticed that the child is always touching that area. And patient also sometimes admit, yes, I pull hair, right? So these are the differential diagnoses. So management of tinea capitis. In infants, very common, this tinea capitis. So we treat with antifungal shampoos during bathing and creams twice a day. That's all, right? For about 1 month, they have to apply. Here, 4 to 6 weeks, they have to apply. Then, in older children, we give oral antifungal, depend on the severity and the age of the patient. So, all three drugs, terbinafine, itraconazole, griseofulvin are effective, but we have to give for 4 to 6 weeks or until it cures. We can't say exactly this is the period until it cures, right? So Chirion. Chirion is again a ringworm infection of the scalp, but it's a very severe pattern of reaction, right? Because of the organisms, different organisms, because these organisms are zoophilic. These most of the children get this, mostly children, from infected cats or dogs. Trichophyton species are there, Verrucosum or Mentagophrines. So these species are zoophilic. And it is not infectious. There's no human transmission. So recently we had a child, the school teachers and the principal have stopped them coming to school for more than, I think, because it takes long time to treat, 3 to 4 months. So this child had not gone to school for about 6 weeks. So we didn't know. After cure only, my mother told us, right? So there's no human transmission. So they can go to school if the child is okay, they can go, right? And it is not contagious, right? So differential diagnosis is abscess. Again, from OPD, these children are sometimes referred to surgical unit. That's okay, because most of the surgeon, they identify this and refer back to us. Because surgery is not indicated here, right? Surgery will cause a scar. We can cure them without leaving a scar, right? So how you differentiate abscess and chirion? If a child has this large abscess, they should be ill and with fever. If it is an abscess, this is a large abscess. So the child should be ill with fever, right? But in Kirion, they are not ill. They are afebrile, no fever. And the history is very short. Within 1 or 2 days, few days, 3-4 days, they have developed these large lesion, right? That is how you differentiate Kirion and abscess. So management, again, both terbinafine, griseofulvin, even itraconazole is effective, right? All 3 drugs. But only problem with itraconazole is we have to treat for 3 to 4 months. So definitely they will get gastritis. That's why usually I don't give itraconazole because of this side effect. So I start either terbinafine or griseofulvin. In hospital, we start griseofulvin. So we have to treat until it cures. We decide. Until there's no inflammation, we have to treat. So it takes about 3 to 4 months. It takes a long time. So we ask them to continue their day-to-day activities as usual because it takes a long time to cure. So if treatment is delayed, like if they come late to us, the problem is the hair follicles might die permanently because it affects the hair follicles directly. So hair follicles might die permanently. They can get a permanent scarring. So even with permanent scarring, we can do scar reduction surgery. We just cut off the scar and approximate the skin and suture, right? So this is not scar actually, this is after 1 week. There's a rapid response to antifungal treatment. This is on admission, like when they came to our clinic, we don't admit actually. We treat like outpatient. This is when they came to our clinic. This is after 1 week. We get down in 1 week and see. So there's rapid response, but we have to treat until there's no further new lesions or inflammation, right? So it takes about 3 to 4 months to completely cure the problem. That is Kirion. The other one is Candida infection. Candida infection. Candida infection is a yeast infection. Again, Candida is a commensal in our body. So it is not an infection coming from outside. It is an overgrowth of commensals. So we have to look for patient factors, not the fungal factors, organism factors, patient factors. What has caused this overgrowth of commensal, right? So we have to look for these patient factors, whether patient has diabetes, whether the patient is obese, you can see obviously. So if it is obese, it affects flexures, right? So this is a toe web infection, this is a finger web infection. This is due to wet, moist conditions. So with the anatomical deformity or that they are working in a wet environment all the time, they can get this wet, moist condition. Housewives, or when they are working in a wet environment like farmers, fishermen, right? And wet occupations, fishmongers and tea makers. Tea makers means tee hadanaya in Kadawal, and the people who wash all the time, like in the tee Kadawal dishwashers, right? Domestic servants. So these are the predisposed. Or even sometimes people come and say like they have a elderly mother or father who is bedridden. So they have to look after them, wash every time. So these are wet, moist conditions. predisposing to this overgrowth of candida infection. Or if you can't find anything else, you have to ask for this obsessive compulsive disorder. Like some people wash their hands very frequently, more than 10 to 20 times they wash their hands. We have found even children with OCD who had candida infection. So it's very important to avoidance of this predisposing factor. Without that, we can't cure this fungi. Right? So this is candida on palms. Like you may have seen this in housewives and some elderly women who wash all the time. They have this burning sensation on creases, palmar creases. This is candida infection, right? Burning sensation, they complain due to frequent immersion of hands in water. So infections start in creases, but later on it can spread to other areas. But most of the time when it is on the creases, they seek treatment. So the other one is intertrigo. Intertrigo is candida infection of flexures, again due to collection of moisture, right? Again, you can see this one. These are candida infection on flexures, right? So the predisposing factors are if they have pendulous breast, large breasts. So they get this candida or intertrigo on submammary areas. When they are obese, on abdominal creases and groins. Even without these anatomical predisposing factors, they can get due to poorly controlled diabetes, right? So you have to look for those causes and we have to advise them on whatever the preventive measures. So treatment of candida infection. Topical therapy. Again, clotrimazole, miconazole, terbinafine creams you can use. Continued for about 2 weeks, but may required for a longer period, right? Systemic therapy. The important thing to remember is this yeast, either candida or malassezia. Griseofulvin is not effective. Griseofulvin is not effective on yeasts. So we have to treat with either itraconazole or terbinafine. Sorry. Terbinafine. Itraconazole we give for 2 weeks, terbinafine 2 weeks. So you can see now for candida infection, we treat only for 2 weeks. Because what is most important thing is removal of predisposing factor. Without that, no use of treating candida infection, right? Because it will recur again. So advice of prevention of recurrence, keep the area dry. To keep the area dry on submammary areas and obese people on flexures, we can use candid powder. It is a powder plus there's antifungal. So you can use candid powder and control diabetes. So these things are very important. Therefore, for candida, we use only for few weeks, 2 weeks, 1 or 2 weeks. We just kill the candida for a short time. Then after that, they have to practice all these preventive measures. Otherwise, candida will recur again and again. So this is onychomycosis. Onychomycosis is fungal infection of the nails. And causative organisms are all 3: dermatophytes, non-dermatophyte molds, and candida. Right? All these can cause onychomycosis. But for our management, that is not important. What type of infection or organism is there is not important for us. right? Clinically, we cannot differentiate species clinically. So if you look at this, you can't tell what species it has caused, right? So this is always a clinical diagnosis. No need to do fungal cultures. Fungal identification or culture is not necessary to treatment. So onychomycosis, you just treat, right? Treatment. One is you start with topical treatment. If it is a mild infection and distal infection, like you can see, only distal part is affected. And if it is one nail involved, we can treat with topical treatment only, right? So systemic therapy, we have to give terbinafine 6 weeks for fingernails and 12 weeks for toenails. In between treatment is not effective. So if you decide on giving systemic therapy, for fingernail infection, you have to give for 6 weeks. For toenail infection, 12 weeks, that is 3 months. Itraconazole again, we can give pulse therapy. That is for 3 months. For fingernails, we give 2 or 3 pulses. For toenails, we give 3 or 4 pulses. That is, we give 1 week per month. 400 milligram daily for 1 week, we give. Then 3 weeks, no drugs. Again, another 1 week, 3 weeks off, another 1 week. So you have to give either 3 pulses or 4 pulses. So if you decide on systemic therapy, you have to give all these. If not, don't start systemic, topical. So when you give topical treatment, you can cut the damage. So you can totally either, if it's a single nail, you can totally remove this nail. Now, this upper one, the whole nail is affected, but it's only one nail. So you can remove the nail plate and start topical application and systemic therapy. So the lower one has some areas only. So you can cut the damaged areas distally. This is nail avulsion. This area, you can cut the nail and then treat. Right? So that is, you remove fungal elements mechanically first, then you treat with topical or systemic therapy. Actually, that helps faster cure. So, like this is a one nail affected, but this is after cure. This is a single nail involvement. This is after cure, right? So there are 2 types of cure: mycological cure, clinical cure. Mycological cure is negative repeat cultures. Like if you do the culture first, then if you repeat it after your treatment, if the fungi are negative, that is mycological cure. But that is not important to us or the patient. The patient are worried whether they get clinical cure, whether their nail is properly or come back to normal, right? But we can't assure that. Even if we treat for these 2 to 3 months, toenail 4 months, we are not going to assure that. We tell them, no, we can't tell whether you will get the normal nail. And how long will it take to get the normal nail also, we don't know, right? So clinical cure, they can continue topical treatment until clinical cure because there are no side effects. So fingernails, they can continue more than 6 months topical treatment, toenails more than 12 months, but we don't repeat again systemic therapy. So systemic therapy is over after this treatment, right? There are no more fungi. Even if we don't do cultures, that is our assumption. No more fungal, right? So onychomycosis or paronychia. Sometimes it's difficult to differentiate. So paronychia is inflammation of nail folds. So you can see there's an inflammation of nail folds. So in onychomycosis also they can get inflammation of nail folds, right? So in these patients also you can see in this patient there's inflammation of the nail fold. So there's paronychia in onychomycosis also. And there are conditions where the primary problem is paronychia, that is inflammation of the nail, right? So sometimes we can't differentiate because in onychomycosis, nail plate is affected first, then they get paronychia. But in paronychia, nail fold is affected, but nail plate also destructed with time, right? When it prolonged for a long time, nail plate also destructed. So we can't differentiate. So there are paronychia, there are two types, acute paronychia and chronic paronychia. Acute paronychia is a bacterial infection. It's very painful, acute condition, 1 or 2 days, single nail involvement. It's due to bacterial infection. So you treat with oral antibiotics and drain the abscess, right? That is acute paronychia. So what is chronic paronychia? It's a very chronic problem. And so most of the time when they come to us, in both hands, more than 2 or 3 nails are affected, right? And their complaint is not pain, but it is itchiness and burning sensation on this nail folds. That is their problem. It is not painful, but itchiness and burning sensation. Almost all the nails involved. It's a long duration. If you ask the history, it had been there for a long time, which they have ignored. So the predisposing factor is frequent immersion of hands or feet in water. Again, housewives would handle same these things, right? Predisposing factors. So management, the most important thing is keep hands or feet dry. So you can ask them to apply an antifungal lotion, 3% thymol spirit or clotrimazole lotion, because there's candida superinfection, right? Candida is not the causative factor here, but it is only a superinfection. So we give antifungal lotion, and most important thing is keep hands or feet dry. So those are the superficial infections. These are the subcutaneous fungal infections. I don't go into detail because if you see these infections, anyway, you have to refer to a specialist clinic. One is mycetoma, is a very chronic problem. And so far, there's no treatment. There are various treatments, but most of the time, no cure. It's a very chronic problem. Rhinosporidiosis, you can see this erythematous nodule on the nose, can occur on the skin also. If it is on the nose, inside the nose, nasal mucosa, they are referred to ENT surgeons, but again, no cure. It recurs again and again. Then this is chromoblastomycosis. Again, that until very recently, there was no cure, but now we found a curative treatment, right? For chromoblastomycosis only, right? Not other things. So this one, this is a 75-year-old farmer. He has had this lesion for 12 years. He came to Kaluthara Hospital when I was there. And his request was, he was suffering from this for for 12 years and it's very smelly and he can't go to other places like outside with other people because of the smell. So he requested us to amputate the feet. Actually, so he has been on treatment for 12 years, not with us at Kalgovila Hospital, but ultimately he came to Kalutara. So actually, but orthopedic surgeon said, no, the joint is perfect, I can't amputate. So we thought of trying a treatment, which was actually not me, but it was published with one patient. They have tried on one patient, and that was on in public. Was in journals. So I searched internet and found this treatment. That was they used intralesional. On the lesion, they injected amphotericin B with oral terbinafine. Because this is a large lesion, I did a debulking. I asked the surgeon, so surgeon removed everything, and around the wound, edge of the wound, we infiltrated amphotericin B because the patient said to amputate. No? So we were scared of gangrene, peripheral gangrene, but because he requested amputation, we thought of trying it. So we did, but it was cured. So this is it. Now we are practicing this. And this also I published, and now we are practicing this in Sri Lanka. So we found a curative treatment for chromoblastomycosis until this chromo get resistant to these drugs, right? So anyway, now it is curative. So we published this again, our findings. This particular one, International Journal of Dermatology, and with 16 patients cured, we have published that in International Journal of Pharmacology. So we found a curative treatment for chromo only. So in principles of management, don't in topical treatment. You should not do in topical treatment. Do not ever prescribe combination of antifungal and steroids to any skin problem. Not only fungal, any skin problem. No indication. Only indication is seborrheic dermatitis. That is also we use Candacort. Candacort has antifungal and hydrocortisone. It's a mild steroid. Candid B has betamethasone. NMGM has clobetasol. There's no indication to use these two in skin problems, right? So use only antifungal creams if you suspect fungi, or only steroid if you suspect eczema, right? Do not prescribe potent topical steroids like clobetasol. This has clobetasol, right? Clobetasol to face, groins, or to children. So we have seen this mistake, and it has caused a big problem in Sri Lanka, causing resistant tinea infection, right? So don't do that. Principles of using topical steroids. I thought it is worth adding this also. One is use steroid very sparsely, right? Even in eczema, if you when you prescribe steroid, you have to ask them to stop steroid when it is cured. It is not a preventive treatment. It is only for the curative treatment, right? So they should not apply because it causes atrophy of the skin. Infants can get cushingoid even with topical steroids, right? So you have to stop steroid as soon as the problem is over, even with eczema, right? So hydrocortisone is the mild one we use in children, even in adults. face and flexures, hydrocortisone. In infants, we use 0.5%, and all the others, all the children and adults, we use 1%. So betamethasone is a moderate potent steroid. In adults, we can use trunk and limbs, but not on flexures, right? Clobetasol is a potent steroid we use only in adults. Even in adults, palms and soles and scalp psoriasis only, right? Palms and soles, scalp psoriasis only. Do not use in other areas, even in adults, right? So ointment, so there are in steroids, there are ointments and creams. Ointments you will be used for dry, scaly areas, scalp psoriasis, lichenified eczema, palms and soles. Creams, oozing areas like acute eczema, right? So dermatology is a visual diagnosis. You may have noticed, I think sometimes some physicians are not happy with us because we diagnose everything clinically. They are not happy. So to satisfy them, sometimes we do biopsy. So we do biopsy to diagnose. Only investigation we do is the skin biopsy. That is also very selective. If we can't diagnose clinically, we'll be doing biopsy. So it is always a visual diagnosis. So it is visual diagnosis is the most important tool in diagnosing skin diseases. So you have to get familiar with more and more clinical photographs, right? So even if you are not in a skin clinic, you can see these pictures. So there are books written by us, and these books are in PGIM and SLMA libraries. So we have donated these books to these places. So you can look at these pictures and read the figure legend. If you are not interested in reading the text, look at the picture, read the figure legend, right? So we'll go to questions now. Now you have to answer, right? Can you eradicate candida or malassezia from our skin? We can't eradicate because they are commensals in our body. We can't eradicate, right? No, because they are commensals. That is why when we treat candida, we are not interested about the killing the fungi. What is important is finding the predisposing factors and treating the predisposing factors. Malassezia is the same. We can't cure, we can't completely eradicate the problem because therefore it recurs, like dandruff, versicolor, even seborrheic dermatitis, it recurs again and again, it comes, right? So second question, what has caused drug-resistant tinea infection we encounter today?
I think steroids, madam. Use of
Yes,
steroids.
yes, using these steroids. Yes, the answer is use of topical steroids or steroid plus antifungal combination on fungi. It is a very big problem now because these fungi we have now is resistant to all three drugs we have, itraconazole, terbinafine, and griseofulvin. So the fourth drug has come, that's voriconazole, is very expensive. 200 milligram is 800 rupees. So we have to treat about 3 weeks. So it takes about 16 to 20,000 rupees to treat that. It's very expensive. So that's a fourth drug because of this drug-resistant tinea infection. So don't use steroid or steroid combination on fungus. So how do you differentiate tinea from eczema? That is the biggest problem now. That is why you give steroid and this combination. You can't differentiate. You just give this combination thinking that this will cure. මොකක් වුණත් කමන්නේ හොඳ වෙලා යයි කියලා තමයි දෙන්නේ. So how do you differentiate these two? Can someone answer?
I think in the tinea, there's a raised inflammatory edge at the
Yes.
edge with in eczema. There's no such thing.
Yes. So that is how you differentiate. Look for this active inflammatory edge. I showed you some pictures. Like if you look at from the, look at small area, you might not see. So look at the whole thing and look for the edge and see whether there's active inflammatory raised edge. But if they have applied steroid before or partially treated, you might not see the edge, right? So actually we can do skin scrapings and mount in 10% KOH and look at under microscope. I showed you microscopy earlier, but usually we don't do it. It is not routinely done, right? So the fourth question are enderm GA, beclomine. Drugs, I can't remember names. Are they miracle drugs which cure all skin ailments? ඒ වගේ තමයි සමහරු දෙන්නේ. හැම එකටම enderm GA, හැම එකටම beclomine. So are they miracle drugs which cure all skin ailments?
No, madam. They give temporary, I think, symptomatic relief without
Yes.
giving the cure.
Yes, yes. It gives only symptomatic relief because with steroids, inflammation subsides, itching subsides. For about 3 to 4 days, they are okay, but it gets worse. So these are not miracle drugs. They don't cure any skin disease, remember that. Only indication to use steroid plus antifungal combination is seborrheic dermatitis. That is the only indication. වෙන කිසි දෙයකට දෙන්න එපා. Right? Fifth one, does chronic paronychia need antifungal treatments? දැන් අපි දන්නවා it's a chronic paronychia is a very common problem. Like most of you I have seen give fluconazole for months, right? Anyway, fluconazole 150 milligram weekly is very harmless, like I can say less side effects, but does it help chronic paronychia? මොකක්ද උත්තරේ? Chronic paronychia is due to there's only candida superinfection on damaged nail folds. The primary problem is inflammation of nail folds. So candida is not the causative factor. Long-term antifungal does not help, right? Topical antifungal is okay because there's superinfection. Because there's a damaged nail fold, there's a superinfection of candida. So topical is okay, but don't give systemic antifungals. That doesn't help at all. Right. Any other questions?
I think there were several questions in the chat box, but at the moment, I think it is bombarded with the answers. So I have some screenshots of the initial questions that were put on the chat box, madam. I'll just
How do I
take.
get them? I can't see anything, no?
Yes, madam. I think they are gone because of there are so many messages put as answers. Anyhow, anyway, I have some questions, madam, which I've taken at the initial part of the lecture. One has asked, what is that you have already answered, madam. One has asked
It's okay. Okay,
separate,
because it's a repetition of it.
in separate. One has asked in seborrheic dermatitis, which is a fungal infection, we usually treat with 1% hydrocortisone and miconazole together. So can we treat fungal infections with steroids then? That means that's the question, madam.
Yes, yes. So steroid and antifungal combination, only indication is seborrheic dermatitis. But again, seborrheic dermatitis is caused by Malassezia species, which is a commensal. So seborrheic dermatitis recur again and again. Again, when there's a commensal overgrowth, we have to look for patient factors. So patient factors, then in seborrheic dermatitis also, we don't know why it comes. Like they didn't have the problem earlier, but suddenly they get seborrheic dermatitis. But like that, seborrheic dermatitis goes away also suddenly. Because it is not the infection problem, but the problem is with the patient factors. Skin pH, difference in skin pH, or the environmental factors, or some has caused overgrowth of this Malassezia species. Even for us, it is rather difficult to cure. I explain it when they come
Right.
to us.
Yes, madam. Then there's another question: is there a prophylaxis for tinea in case of patients cannot be isolated, like in setups like army, madam?
No. And one thing is you don't have to isolate. They get direct infection. Direct infection can, in army personnel, they get from their clothes. They share their clothes. You know, these army fellows, they share. And sometimes there are uniforms, some specific uniforms, if you ask them, they have to use from the collection. එතනින් අරගන්නවා අඳිනවා do the මොන හරි exercises they do and keep it again. And ඒවා one by one they don't wash. So it's because of sharing clothes they get. So we advise these people with tinea infection to use their own towels and separate their clothes from other family members, right? So these days we get all the family affected. That is direct infection එකක් එන්නේ.
Right.
Not
Okay,
from
madam.
air or anything, right? So no
There's
need to isolate.
Yes, madam. And then there's another question, madam: how can we use fluconazole in candida infection?
That I answered. Fluconazole is 150 milligram weekly. That is, you can use. But I don't think it is helpful. Fluconazole we use in immune compromised patients, right? Like in cancer patients on cytotoxic drugs, if they get oral candidiasis, right? So initially we treat with itraconazole for 5 days. But after that, the patient is continuously on cytotoxic drugs, right? So the predisposing factor is immune suppression. We can't stop that. But for prophylaxis, we can give fluconazole 150 milligram weekly. That is for prophylaxis, not for treatment. Treatment, we give itraconazole for 5 days. Okay, then in cancer patient, fungal therapies for 1 week. Like we can't cure that person because he is still on chemotherapy. So for prophylaxis, we can give. Otherwise, for candida, give itraconazole.
Right. Okay, madam. This is the very first question that was put in the chat box, madam: how to differentiate between aluhang and pityriasis alba?
Aluhang and alba, both. Now alba only on face. That's a condition of dry skin, mainly in children, right? Hypopigmented patch with dry skin. So aluhang is very well demarcated because it's a fungal infection. Aluhang is a fungal infection. All the fungal infections are very well demarcated. I'll show you the first slide. See, this is very well demarcated. And there's scaliness. But alba is not well demarcated. Like a very diffuse hypopigmentation on mainly on cheeks, and it's due to dry skin. And alba wala, you don't get this satellite lesions. right?
Right.
Any other question?
No, madam. Those are the questions at the moment. So I thank Dr. Rantilaka Ranaveka, consultant dermatologist LRH, who has given a very informative lecture and has given the references at the end. You can uh, refer in the SLMA as well as in the uh, PGIM library. So thank you very much again, madam, and I thank all of you. We have today, I think, nearly 400 participants for this lecture. And for those who have missed and who want to revisit the lecture details, you can. We will upload this lecture at the within today or tomorrow itself to the SHRI YouTube channel. You can revisit the lecture as well. And I again thank all of you, and especially Dr. Antilaka Ranavaka, consultant dermatologist, for joining with us today in a Sunday morning like this, which is of course free time to educate us and this very informative lecture. I think this one comment was there saying that this is the very informative, I mean, to the point lecture we had in this whole series. So that is a great comment. So thank you again, madam, for educating us today. Yeah, link for the certificate will be put in the chat box right after, so you can follow that link and get you the certificate. Again, I thank all of you and hope you will join in with us next lecture on the next Sunday as well at the same time in the same link. We will be sharing the link. Thank you.
Okay, thank you.